All right, friends, welcome to the liver. And let me just say this up front. If organs were employees, the liver would be the one quietly doing everyone else's job while never calling in sick. Seriously, the liver performs over 500 known functions, which makes it less of an organ and more of a biochemical manufacturing plant. In this lecture, we're going to focus on three big ideas: what the liver is supposed to do, what happens when things go wrong, and what it looks like when cells decide to grow when they absolutely should not. From a histotechnology perspective, the liver is one of those organs where architecture matters tremendously. When disease develops, the first clues are often structural, so altered cords, widened sinusoids, and fibrosis patterns. Things that you help preserve and demonstrate with high-quality tissue processing. So as we move forward, don't just think physiology, think, what would this look like on my slide? Would fixation impact interpretation? Is this tissue fragile, fatty, fibrotic? Because liver specimens can absolutely humble even experienced histotechs. I know I've said this earlier, but some worthless knowledge. Here, the liver is the only visceral organ capable of regenerating up to about 70% of its mass, which is impressive, but also it explains why surgeons are so comfortable removing large portions when necessary. All right, let's build the structural foundation next. Before we talk pathology, we need to ground ourselves in normal flow, because liver disease is really just a story about disrupted traffic patterns. Blood enters the liver through the portal vein, carrying nutrients, toxins, medications, and metabolic byproducts. Basically everything absorbed from the GI tract that now needs to be processed. Think of the liver as the body's customs checkpoint. Nothing gets through without inspection. Now let's talk cells. Hepatocytes. These are the parenchymal workhorses, metabolizing drugs, producing bile, storing glycogen, and synthesizing proteins. Histologically, they organize into cords, which is important because when disease strikes, that beautiful organization is often the first casualty. Between those cords, sinusoids. Not quite capillaries, more like low-pressure vascular hallways that allow maximum exchange. And inside them live one of my favorite liver residents, the Kupffer cells. These macrophages are professional garbage collectors, clearing bacteria, debris, and worn-out red cells. Histotech tip you only appreciate after seeing bad sections: overfixation can make sinusoids collapse, while poor processing can exaggerate spaces and mimic pathology. Interpretation depends heavily on preparation here. And finally, bile. Tiny channels called bile caniculi run between hepatocytes, carrying bile in the opposite direction of blood flow. Yes, the liver is managing two directional traffic systems simultaneously. Fun fact, about 75% of liver blood supply is venous, not arterial, which is extremely unusual for an organ. Translation, the liver operates in a relatively low oxygen environment, which becomes very relevant when we talk ischemic injury later. Now let's put the map together. On the left, you see the classic diagram of a hepatic lobule. On the right, the real-life histologic version. Your job as a histotechnologist is often helping turn the right image into something interpretable instead of chaotic pink noise. Let's orient ourselves. The portal triad. So each triad contains a portal vein branch, a hepatic artery branch, and a bile duct. Three structures traveling together. Very efficient packaging. Blood flows from the portal triads inward toward the central vein, bathing hepatocytes along the way. This creates metabolic zoning. Periportal cells get the richest oxygen supply, while cells near the central vein live a slightly more dangerous lifestyle. Guess who dies first during hypoxia? Yep, central lobular hepatocytes. You'll see that pattern again and again. Good embedding orientation can sometimes help preserve recognizable lobular structures, especially in wedge biopsies. Poor orientation? Well, everything looks like abstract art. Some worthless knowledge, but actually memorable. If you ever get lost in liver histology, find the central vein. It's the drain at the center of the sink. Now we're zooming in because the liver is where microanatomy really earns its paycheck. Look closely at the sinusoid structure. Unlike typical capillaries, sinusoidal endothelial cells are fenestrated, meaning they have little openings that allow plasma to directly interact with hepatocytes. Between them sits the space of DC, which is not a vacation destination but is critically important. This is where nutrient exchange happens. It's also where things go sideways during fibrosis. Then there's stellate cells, normally quiet vitamin A storing cells, but when the liver is injured, they activate and become collagen producing machines. And just like that, soft liver becomes stiff liver. Histologically, this transition is dramatic, and recognizing it early matters. Histotech Pearl. Fibrotic liver can cut very differently than normal liver. Expect increased resistance during microtomy, ribbon compression, occasional language not appropriate for the workplace. So adjust your blade angle early, save your sanity. A fun fact, the liver receives about 25% of cardiac output at any given time, which means every minute a massive volume of blood and whatever is in it is interacting with this microscopic architecture. No wonder things go wrong here so often. All right. If the gallbladder is storage, the liver is the biochemical factory of the body. Truly one of the hardest working organs we will ever process in the lab. Let's start with the star of the show, the hepatocytes. These polygonal little overachievers are responsible for hundreds of metabolic processes happening simultaneously, such as fat metabolism. So the liver produces bile, which emulsifies fats, essentially breaking large lipid globules into smaller droplets so enzymes can actually do their job. When this system fails, fat accumulates inside hepatocells. So hello, steatosis. And yes, those vacuolated hepatocytes you see on slides, that is literally metabolic traffic congestion. Protein synthesis. The liver produces major plasma proteins like albumin and clotting factors. Fun fact, if albumin drops, fluid leaves the vasculature and patients can develop ascites. So when you see a distended abdomen clinically, think failing hepatocytes. Carbohydrate metabolism. The liver regulates blood glucose by storing glycogen and converting nutrients into triglycerides when energy is abundant. Worthless knowledge moment. After a carb-heavy meal, your liver is basically running a biochemical Costco, storing bulk energy for later. Storage. The liver keeps reserves of glycogen, iron, copper, and fat-soluble vitamins such as A, D, E, and K, which explains why liver disease often leads to bleeding disorders. Vitamin K storage becomes compromised. Detoxification. Drugs, hormones, toxins, metabolic waste, hepatocytes process them all. Histotech Pearl. Many toxins cause predictable zonal injury patterns in the liver lobule. Pathologists love asking which zone is affected, and now you know why that matters. Bottom line, when hepatocytes struggle, the entire body notices. Let's zoom in on bile for a moment because it is far more sophisticated than people realize. Bile salts are derived from cholesterol and organize themselves into tiny spherical structures called micelles. Think of micelles like molecular dish soap. They surround lipids with a water-friendly exterior so fats can travel through the watery environment of the intestine. Without micelles, fats don't absorb. Patients develop fatty stools and vitamin deficiencies. Histotech connection. Cholestasis often shows up microscopically as bile plugs. Once you've seen them, you won't mistake that greenish-brown pigment again. The bonus job is clearing bilirubin. Bilirubin comes from broken down red blood cells. The liver conjugates it so it becomes water soluble and can be excreted. When this process fails, we see jaundice. Fun fact students remember forever, newborn jaundice happens because their hepatocytes are still metabolically immature. Tiny liver, but big workload. Now let's connect structure to diagnostics, because this is exactly where histology meets clinical medicine. When providers suspect liver injury, they often start with labs that answer two big questions. Number one, are hepatocytes injured? These enzymes, AST and ALT, live inside hepatocytes. If cells rupture, these enzymes leak into the bloodstream. ALT is more liver specific, AST is a little less loyal. It also exists in muscle. Clinical pearl, very high elevations usually signal acute injury. Chronic disease tends to produce more modest increases. Number 2, is the liver still functioning properly? This is where we evaluate synthetic ability. Albumin reflects long-term function. PT/PTT is clotting factor production, and ammonia is the detox capability. If ammonia rises, it can cross the blood-brain barrier and cause hepatic encephalopathy. Not something you forget once you see it clinically. Histotech perspective, lab abnormalities often appear before major structural changes are visible under the microscope. So pathology and lab medicine truly complement each other. One shows function, the other shows architecture. All right, now we're going to walk through bilirubin, and I want you to think of this less as memorization and more as logistics and waste management system inside the body, because that is exactly what it is. The liver is basically running a 24/7 recycling plant. Old red blood cells come in, useful components get salvaged, waste gets packaged, and then shipped out. When this system breaks down, clinically, we see jaundice. Histologically, we start seeing pigment deposition, cholestasis, hepatocyte stress, all the fun things you'll absolutely encounter in practice. First, origin story. Bilirubin comes from red blood cell breakdown. Red blood cell lifespan is about 120 days, which is honestly impressive considering they have no nucleus, no organelles, and are basically tiny bags of hemoglobin whose entire personality is carrying oxygen. Once they age out, macrophages dismantle them. Let's follow the parts. Iron, recycled because the body is efficient and iron is valuable. Globin is broken into amino acids. Heme is converted into bilirubin. Now here's a number worth keeping in your mental framework, not memorizing, just appreciating. About 1 milligram of bilirubin is normally circulating. That means your body is constantly producing it, so the liver is never off duty. Histotech tie-in, when production exceeds processing, pigment accumulates, and depending on the cause, you may see hepatocellular injury, bile plugs, Kupffer cell hyperactivity. Your slide may be tiny, but the physiology behind it is huge. Worthless knowledge moment, bruise colors, that's hemoglobin breakdown progressing through biliverdin into bilirubin. So yes, you are literally watching microbilirubin metabolize every time a bruise turns yellow. You're welcome for that visual. Now the key concept here is solubility. Fresh bilirubin is unconjugated, meaning it is not water soluble, which is a problem because blood is mostly water. So what saves the day? Albumin, the Uber driver of the bloodstream. Albumin binds unconjugated bilirubin and safely transports it to the liver. Once hepatocytes grab it, they perform one of their many biochemical magic tricks, conjugation. Now it becomes water soluble, which means we can actually excrete it. If hepatocytes are damaged, this step fails, and that is why hepatocellular disease often presents with mixed bilirubin elevations. Histotech perspective, when conjugation pathways are impaired, pigment can accumulate within hepatocytes, sometimes subtly, sometimes dramatically. Your staying quality matters here. Pigment differentiation is one of those quiet skills that separates good histotechs from great ones. Fun fact, again, newborn jaundice happens because their conjugation enzymes are immature. Again, tiny humans, adorable, but biochemically inefficient. After conjugation, bilirubin gets excreted into bile and sent to the intestine. Now gut bacteria get involved because they always do. They convert bilirubin into urobilinogen. From here, 3 possible paths. 1, most leave in feces, gives stool its brown color. 2, some is reabsorbed, returned to the liver, enterohepatic circulation. And 3, a small portion goes to the kidneys and is converted to urobilin and gives urine its yellow color. So yes, bilirubin is why pee is yellow and stool is brown. You may never look at bathroom biology the same way again. Clinical histology connection. If bile can't reach the intestine, stool becomes pale. Urine darkens, and microscopically you may see bile accumulation before labs even tell the story. Let's tie the entire pathway together visually. Think of it as a relay race. Red blood cell breakdown equals unconjugated bilirubin, which equals albumin transport, and then hepatocyte conjugation into bile, into the intestine, into urobilinogen, and into excretion. Every step depends on the previous one working properly, which means when something goes wrong, the pattern of bilirubin elevation actually helps localize the problem. Prehepatic, hepatic, or posthepatic. And while providers debate causes, we are the ones producing the slides that often confirm it. Histotech Pearl, anytime you suspect pigment, slow down during microtomy and staining. Artifacts love to impersonate bile, so don't let them. Worthless knowledge bonus, before modern labs, physicians sometimes tasted urine to detect abnormalities. So next time someone complains about LIS downtime, just remember, it could be worse. All right, now we're going to talk about something you have absolutely seen clinically, even if you didn't realize it at the time, jaundice. Jaundice is simply the visible result of too much bilirubin circulating in the bloodstream. When bilirubin accumulates, it deposits in tissues, particularly those rich in elastin, which is why we see that classic yellow discoloration of the skin and sclera. Fun fact, the sclera often shows jaundice before the skin because elastin has a high affinity for bilirubin. So if you ever hear someone say, check the eyes first, there is real physiologic reasoning behind that. From a histotechnology perspective, jaundice is not a diagnosis. It is a clinical clue telling us something is wrong, somewhere along the bilirubin pathway. Think of bilirubin metabolism like an assembly line. The red blood cells break down into unconjugated bilirubin, then liver uptake, conjugation happens, and then bile excretion. If the assembly line slows down, breaks, or gets blocked, bilirubin backs up, and where it backs up tells us what type of jaundice we are dealing with. So what actually causes this buildup? Anything that disrupts the formation, processing, or excretion of bilirubin can lead to jaundice. We classify it into three major categories. Prehepatic, the problem happens before bilirubin reaches the liver. Hepatic, the problem is within the liver itself. Or posthepatic, bilirubin is processed correctly but can't exit. If you like mental shortcuts, think too much coming in, liver can't handle it, exit is blocked. Three very different mechanisms, but the patient still looks yellow. For us in the lab, differentiating these becomes critical because the bilirubin fractions in liver enzymes will pattern differently, and that helps clinicians narrow their differential. Let's start upstream. Prehepatic jaundice is typically caused by hemolysis. Red blood cells are being destroyed faster than the body can replace them. Remember, red blood cell lifespan is approximately 120 days, but in hemolytic disorders, that timeline gets dramatically shortened. Now the liver is suddenly drowning in unconjugated bilirubin. And here is the key point. The liver is functioning normally. It just cannot keep up with the workload. It's like being the only histotech on a day when someone drops 400 cassettes on your bench unexpectedly. Could you process them? Probably. Immediately? Absolutely not. So unconjugated bilirubin accumulates. Lab clue you'd often see, elevated indirect bilirubin with otherwise relatively preserved liver function. First, I appreciate whoever made this graphic. The stressed out liver is relatable. Let's walk through what's happening here. Mass red blood cell destruction, excessive unconjugated bilirubin. The liver is trying to conjugate and it just cannot keep up. Meanwhile, more bilirubin enters the gut, which means increased urobilinogen production. Clinical Pearl you may hear providers mention, patients often have darker stools, not pale ones, because bilirubin is still reaching the intestine. Worthless knowledge moment. Before modern lab testing, again, Physicians literally assess stool color as part of diagnosing jaundice type. Imagine charting that today. From a specimen standpoint, nothing special here for fixation or staining, but understanding the physiology helps you interpret why certain liver biopsies may look relatively normal despite obvious jaundice. The problem isn't always structural. Sometimes it's purely metabolic overload. Now we move to the scenario histotechs tend to encounter more often. The liver itself is injured. Hepatic jaundice occurs when hepatocytes lose their ability to uptake bilirubin, conjugate it, or secrete it into bile. Common culprits include viral hepatitis, cirrhosis, toxic injury, or alcohol-related damage. And unlike prehepatic jaundice, this is where biopsy findings can become very telling. Depending on the cause, you might see hepatocyte ballooning, inflammation, fibrosis, steatosis, or necrosis. Now the assembly line isn't just overwhelmed, the machinery is broken. Clinical pattern you'll often see is increased AST and ALT, mixed conjugated and unconjugated bilirubin. Your liver is waving a biochemical distress flag. Quick histotech reminder, diseased liver can be friable, fatty, or fibrotic, so gentle grossing and good fixation matter. Underfixed fatty liver, especially, can artifact quickly. Treat those specimens kindly. All right, now we're shifting into hepatic causes of jaundice, meaning the problem is not before the liver and it's not after the liver. The liver itself is struggling. Think of this as the liver calling in sick but still being forced to show up to work. Normally, hepatocytes take in unconjugated bilirubin, conjugate it, ship it out into bile. But when hepatocytes are inflamed, infected, or replaced with scar tissue, everything slows down. Or worse, stops. So now bilirubin backs up into the bloodstream and that classic yellow discoloration starts showing up. Two major players here, viral hepatitis and cirrhosis. Viral hepatitis is inflammation causes hepatocytes to become swollen and dysfunctional. Picture a hallway packed with people. Nothing moves efficiently. From a histology standpoint, you may see ballooning degeneration, Councilman bodies, which are apoptotic hepatocytes, and lobular inflammation. And yes, those acidophilic bodies are one of those things pathologists love to point out dramatically on scope. Ah, yes, classic. Meanwhile, you're thinking, looks like a sad pink blob. Welcome to pathology. Cirrhosis. Now we escalate. Cirrhosis is not just inflammation, it is architectural remodeling of the liver. Fibrosis forms bands. Regenerative nodules pop up. Blood flow becomes chaotic. Bile flow becomes obstructed. And at this point, the liver is basically trying to function inside a maze. Fun fact, the liver is one of the only organs that will regenerate aggressively, but cirrhosis is what happens when injury outpaces that regeneration. It's the biological version of patching drywall during a tornado. Histotechnologist insight, cirrhotic liver can be firm, nodular, and difficult to section. If you ever gross one, you will immediately know. Your blade will tell you, your wrist will tell you, your embedding tech will definitely tell you. In staining, trichrome becomes your best friend for highlighting fibrosis. Clinical tie-in, because hepatocytes are failing at multiple jobs, labs often reflect mixed hyperbilirubinemia. Both conjugated and unconjugated may rise. The liver isn't processing normally, so everything accumulates. Now we move downstream. Post-hepatic jaundice means the liver actually did its job, but the exit is blocked. Think of conjugated bilirubin lining up politely to leave and someone locked the door. Common causes, tumors in the head of the pancreas, cholangiocarcinoma, gallstones, biliary strictures, anything compressing or obstructing bile ducts. And because conjugated bilirubin is water soluble, it spills into blood and eventually urine, which leads to one of the biggest clinical clues, dark urine and pale stool. Patients sometimes describe stool as clay-colored, not exactly a phrase you forget. If obstruction persists, bile begins backing up into the liver. So as histotechnologists, we may see bile plugs, cholestasis, hepatocyte injury, and bile pigment has that distinctive green-brown, you can't mistake it look. Once you've seen it, you always see it. Worthless knowledge that is oddly memorable, bile is what gives stool its brown color. So when bile can't get there, the stool basically loses its pigment license. This visual is reinforcing a simple but critical concept. Production is fine, conjugation is fine, flow is not fine. Pressure builds upstream, kind of like a plumbing clog, except this plumbing controls toxin removal. Notice how bilirubin accumulates and nothing progresses forward into the intestine, which is why stool becomes pale, urine becomes dark, and skin becomes yellow. The body starts rerouting bilirubin wherever it can. Not efficiently, just wherever. Histotechnologist angle, chronic obstruction can eventually cause secondary biliary cirrhosis. So even though the original problem was post-hepatic, leave it long enough, now the liver becomes structurally damaged too. Pathology loves a domino effect. Now let's talk labs, but not in a memorize this way. Instead, think of labs as answering three big questions. One, are hepatocytes injured? When hepatocytes are damaged, enzymes leak out. Cells are basically waving biochemical white flags. ALT is more liver specific, AST is less picky. It's also found in muscle. So again, context matters. Yes, pathology is rarely as straightforward as we want it to be. Number two, is the liver still doing its job? Look at synthetic function, albumin, coagulation factors, and ammonia. If albumin drops, that tells you this liver is struggling with protein production. And since clotting factors are made in the liver, coagulation times creeping up equals big red flag. Fun clinical pearl, easy bruising is sometimes one of the earliest visible signs of declining liver function. And number three, is bile flowing? Now we look at bilirubin and GGT. GGT is particularly helpful when trying to determine if elevated alkaline phosphatase is hepatobiliary in origin. Also, GGT rises with chronic alcohol use, so sometimes labs quietly tell a story the patient haven't. Histotech perspective, when you see lab panels like this before a biopsy arrives, you can often predict what the tissue might look like. Elevated enzymes, expect injury. Poor synthetic markers, prepare for chronic change. Labs and histology should always feel like they're having the same conversation. Let's zoom out for a second. One of the liver's biggest responsibilities is detoxification. Not just alcohol, not just drugs, everything. Metabolic byproducts, hormones, environmental toxins. If it circulates, the liver probably has to process it. When detox pathways fail, toxins accumulate. One major example, ammonia. Normally converted into urea and safely excreted. But in liver failure, ammonia rises, and that can lead to hepatic encephalopathy. Patients may become confused, lethargic, and even comatose, which is a powerful reminder liver disease is not just a liver problem. It becomes a brain problem, a clotting problem, a metabolic problem, a whole body problem. The liver performs over 500 known functions. 500. Honestly, it is the overachiever of organs. Kidneys filter, heart pumps, liver runs biochemical civilization. When severe liver disease is present, tissue may show steatosis, fibrosis, necrosis, and inflammation. Sometimes all at once because the liver rarely fails quietly. And specimen quality matters enormously here. Fatty liver, for example, cuts very differently than fibrotic liver. Your microtomy skills absolutely show up in these cases. All right, let's talk about one of the liver's most underappreciated superpowers. Again, detoxification. If the spleen is dramatic and the pancreas is temperamental, the liver is that quiet coworker who fixes everyone's mistakes without asking for recognition. Nearly everything you put into your body passes through the liver at some point. Pharmaceuticals, alcohol, supplements, herbal remedies, yes, even the all-natural ones. Fun fact, herbal supplements are one of the fastest growing causes of drug-induced liver injury in the U.S. Natural does not automatically mean safe for hepatocytes. Enter the biochemical celebrity cytochrome P450 or CYP. If hepatocytes had a LinkedIn profile, CYP enzymes would be listed under skills: oxidation, drug metabolism, making toxic things slightly less terrifying. CYP enzymes catalyze drugs so they can eventually be excreted. But here's the twist that students often don't expect. Sometimes the metabolite is more toxic than the original compound. Classic example, alcohol and into acetaldehyde. Acetaldehyde is basically ethanol's chaotic evil cousin. Clinical nuance worth knowing: not everyone metabolizes drugs the same way. There is familial variation in CYP activity, meaning some patients are rapid metabolizers, some are slow metabolizers. This is why one person can take a medication with zero issues while another develops liver injury. When you see central lobular necrosis, drug toxicity should immediately be on your differential radar because CYP activity is highest in zone 3. Bookmark that mentally. It shows up a lot. Drug injury falls into two big buckets. Number one, predicted or dose dependent. Translation: too much equals damage. The heavyweight champion here, acetaminophen. Yes, Tylenol. The medication people think is the safe one. At therapeutic doses, it's fine, but once liver glutathione stores are overwhelmed, the toxic metabolite NAPQI starts destroying hepatocytes, and it loves zone 3. Sense a pattern? Number two is unpredicted or idiosyncratic. These reactions are not dose dependent and are frustratingly unpredictable. Warfarin is a good example to illustrate variability, not because it as commonly destroys the liver, but because dosing differs wildly between patients. Some need higher doses, some need tiny ones. Same drug, same indication, completely different physiologic response. Medicine is humbling like that. Worthless but fun knowledge: about 50% of acute liver failure cases in the U.S. are caused by acetaminophen. Half. From something sitting in most kitchen cabinets. Now we pivot from injury to failure. Failure means the liver can no longer perform its core jobs: detoxification, protein synthesis, bilirubin handling, coagulation factor production. Think of it as a metabolic blackout. We divide liver failure into two categories: acute, which means sudden and catastrophic, or chronic, which is slow architectural destruction. Today, we will start with acute, the dramatic one. Acute liver failure is exactly what it sounds like: a rapid onset of severe hepatic dysfunction in someone who often had no prior liver disease. Again, acetaminophen leads the charge here. Pathologically, what is happening? Massive hepatic necrosis. Not patchy, not subtle. We're talking large portions of hepatocytes dying. Clinical presentation often includes nausea and vomiting, sky-high AST and ALT, sometimes in the thousands, and yes, that should make you nervous. Jaundice, shrinking liver from parenchymal loss. But here's where things get especially dangerous. The failing liver cannot clear ammonia. Ammonia crosses the blood-brain barrier and causes cerebral edema and leads to hepatic encephalopathy. Patients become confused, then obtunded, then comatose. Meanwhile, the liver also isn't making clotting factors. So now we have brain swelling, coagulopathy, not a great combination. Biopsies are not always performed in fulminant liver failure because bleeding risk is so high. And when tissue is obtained, expect to see massive necrosis and collapse of reticulin framework. It is striking under the microscope. One of those slides students remember forever. Before we go deeper into pathology, let's recalibrate your visual baseline. Because if you don't know normal, you will never confidently recognize abnormal. Take a look at this cut surface. What should jump out immediately? Smooth capsule, uniform reddish-brown color, no nodules, no fibrosis bands. The liver should look almost boring. Pathologists love boring organs. Boring means healthy. Fun fact, again, the liver is the only solid organ that can regenerate up to about 70% of its mass. You can remove a huge portion surgically and it can grow back. Show off, but that regenerative ability has limits. Chronic injury eventually replaces regeneration with fibrosis. And that, friends, is how we end up at cirrhosis, which is coming soon to a slide deck near you. All right, let's pause here and really look at this liver. This is acute liver failure, and grossly, it's a hot mess in the most pathological meaning way possible. What you're seeing is massive hepatic necrosis. Hepatocytes are dying rapidly and in large numbers, so the liver loses its normal uniform appearance. Instead of that smooth mahogany brown surface we like, we get this mottled red and yellow look, which reflects hemorrhage, necrosis, and collapsing parenchyma. From a histology perspective, think about what that means for tissue processing. Necrotic tissue is fragile, friable, and poorly organized. The normal lobular architecture is falling apart, which makes sectioning and interpretation, let's say, extra spicy. Acute liver failure is basically the liver saying, I was fine yesterday, and today I am absolutely not. This is rapid, overwhelming injury, not something that's been smoldering for years. Worthless but fun knowledge, in severe acute liver failure, the liver can actually shrink because there's so much cell loss and structural collapse. So yes, sometimes organs fail by disappearing. Now we're shifting gears from fast and furious to slow and relentless. Chronic liver failure is the result of repeated injury over time. The liver gets hurt, tries to repair, gets hurt again, repairs again, and eventually runs out of good options. Common causes you'll hear again and again are chronic hepatitis B or C, alcoholic liver disease, and non-alcoholic fatty liver disease. Different insults, same outcome: ongoing inflammation and hepatocyte damage. Histologically, chronic injury means persistent inflammation, activation of stellate cells, and progressive fibrosis. This is the liver stuck in repair mode, and repair is not the same as restoration. Think of it like repeatedly patching drywall instead of fixing the leak. Eventually, the wall is just layers of spackle. This is where chronic liver failure earns its final boss form, cirrhosis. Cirrhosis is the end stage of chronic liver injury, where normal architecture has been replaced by fibrous septa and regenerative nodules. The liver is trying to regenerate. Hepatocytes are dividing, but they're doing it inside a fibrotic cage. Grossly, that's why the liver surface becomes nodular, firm, and irregular. Histologically, we see thick bands of collagen surrounding nodules of hepatocytes that no longer communicate normally with the portal triads or central veins. So yes, there are hepatocytes present, but they're poorly organized, poorly supplied, and poorly functional. This is repair without a blueprint, and it does not end well. Analogy moment, it's like rebuilding a city where all the roads are blocked by concrete barriers. The buildings exist, but nothing flows the way it should. One more important consequence of cirrhosis that we cannot ignore: cancer risk. Cirrhosis is one of the strongest risk factors for developing hepatocellular carcinoma. Why? Because chronic injury plus constant cell turnover is a perfect storm for genetic mistakes. From a histology standpoint, this means cirrhotic livers often need very careful sampling. Nodules can look deceptively similar grossly, but microscopically they may tell very different stories. Cirrhosis doesn't just change how the liver looks, it changes how vigilant we need to be when evaluating. Quiet but important takeaway: regeneration is not always a good thing when it happens in the wrong environment. Now let's talk about blood flow, because the liver is nothing without it. In cirrhosis, all that fibrosis makes the liver rigid. Blood trying to pass through the hepatic sinusoids suddenly meets resistance. And blood, like students during finals week, does not like resistance. As pressure builds, it backs up into the portal venous system, leading to portal hypertension. The body responds by finding alternate routes back to the heart, forming what we call portosystemic shunts. These bypass routes allow heart to skip the liver entirely, which might relieve pressure, but it also means toxins are no longer being filtered efficiently. From a histology perspective, remember, altered blood flow equals altered oxygen delivery equals further hepatocyte stress. Cirrhosis is not just a structural disease, it's a hemodynamic one. Analogy, this is basically a traffic detour system that keeps the cars moving but skips the toll booth entirely. Okay, let's talk about one of the more dramatic physical findings in liver disease, caput medusae. And yes, it is named after Medusa, because those distended abdominal veins radiating from the umbilicus look like snakes coming out of her head. Medicine loves mythology almost as much as it loves Latin. So what's actually happening here? This is a direct consequence of portal hypertension. When the liver becomes cirrhotic, fibrotic bands squeeze down on the sinusoidal spaces. Think of it like stepping on a garden hose. Pressure builds upstream. Blood now struggles to move through the liver efficiently, so it does what blood always does. It finds a detour. The body opens up collateral circulation, specifically portosystemic anastomosis, allowing blood to bypass the liver and return to systemic circulation. One of those bypass routes is through the periumbilical veins, which normally carry very little blood, but under high pressure, they dilate, they twist, they become extremely visible. From a histology perspective, remember, this all starts with architectural distortion of the liver, fibrosis, regenerative nodules, collapsed sinusoidal pathways. Once normal microcirculation is disrupted, macro problems follow. Fun but slightly horrifying fact, these veins can actually rupture. Portal hypertension is not just visually impressive, it's dangerous. So when you see caput medusae, don't just think cool clinical sign, think severe intrahepatic resistance, failed sinusoidal exchange, advanced cirrhosis. Your histology brain should immediately picture scar tissue strangling hepatocyte plates. Now let's break back into the liver, because the real tragedy of cirrhosis is happening at the microscopic level. When fibrosis redirects blood flow, hepatocytes are essentially bypassed. Blood that should percolate slowly through sinusoids is now rushing through abnormal channels. Less contact time equals less detoxification, and that brings us to ammonia. Normally, hepatocytes convert ammonia into urea via the urea cycle, nice and safe for renal excretion. But when hepatocytes fail, ammonia rises, and ammonia is very unfriendly to the brain. This leads to hepatic encephalopathy, which ranges from confusion to personality changes to coma. Students always remember this when I tell them. The brain does not appreciate being marinated in nitrogen waste. Now, let's talk macrophages. Who are the resident macrophages of the liver? The Kupffer cells. These guys line the sinusoids and act like microscopic security guards, grabbing bacteria, cellular debris, and anything suspicious coming from the GI tract. But cirrhotic distortion separates blood from Kupffer cells. So now pathogens slip through unchecked, which is why these patients are incredibly infection prone. Worthless but fun knowledge, Kupffer cells were discovered by Karl Kupffer in 1876, who initially thought they were endothelial cells. Science is a journey, so histologically, what should you picture? Capillarization of sinusoids, loss of fenestrations, fibrotic barriers, and reduced hepatocyte exposure, as well as ineffective Kupffer surveillance. Basically, the liver becomes a poorly staffed airport with broken security scanners. Not ideal. Cirrhosis is not a quiet disease. When the liver fails, multiple body systems immediately feel it. First up, ascites. This is fluid accumulation in the peritoneal cavity, and it happens for two major reasons. Portal hypertension pushes fluid out of the vessels. The liver stops producing enough albumin. Remember, albumin maintains oncotic pressure. No albumin equals fluid leaks into tissues. It's basically Starling forces betraying us. From a histology lens, think of this as another downstream effect of hepatocyte dysfunction. Next, coagulopathy. Most clotting factors are synthesized in the liver, so when hepatocytes go offline, clotting factor production drops. These patients bruise easily, bleed longer, and surgical procedures become much higher risk. And then, one students never forget, gynecomastia. The damaged liver cannot properly metabolize estrogen, so estrogen levels rise. In males, this leads to breast tissue development. Clinical Pearl, when you see hormonal imbalance, always consider metabolic clearance, not just endocrine overproduction. The liver is basically the body's chemical recycling plant. When the plant shuts down, hormones pile up. Quick analogy, a cirrhotic liver is like a city where garbage workers went on strike. Toxins, hormones, and fluid accumulate everywhere. Not the vibe we're going for physiologically.